Thank you again for the opportunity to be here, Dr. Phil Poncerino and Smith & Nephew. What I'm going to talk about today is revision hip arthroscopy, looking specifically at lysis of adhesions, re-repair versus labral reconstruction for this challenging situation. Perfect. Disclosures, all of my relationships have no bearing on the content of this talk. Failure, it's a word that we can't stand as orthopedic surgeons. We're not used to this through our training, and this is something that we encounter in the office sometimes. And I think especially with hip arthroscopy, unfortunately, we do see this. And for me, I can't stand it. I can have a clinic that's fantastic and everybody's doing great, but one person not doing well ruins the whole week. And for me, when I sit down to indicate somebody for another surgery, I want to use what I think is the most predictable to get them well again. And so I guess it leads to the question, why do hip arthroscopies fail? The thing that's seen most in the literature is residual impingement. And I think we all agree with that. And what I said in the first meeting is I think we have to get the machine perfect. If we get the machine perfect, I think a lot of times we're going to win with our soft tissue procedure. Untreated acetabular dysplasia, I think with an oblique or shallow joint, we're certainly going to overload our soft tissue procedure, and so we can lose with our labral repair in those situations. Adhesions, this is hard. Because it has been described, but the question that I always have is that capsule lays over your labral repair. What level of adhesions or scar tissue or healing is normal and what level is abnormal? And I don't think we know that. But certainly in the operative setting, the adhesions become a problem for us logistically to be able to treat or re-repair or reconstruct the labrum. Extra-articular pain generators, we're talking about this a lot more now. And the question is, was it always there and it was a problem that we missed, or is it a problem that surfaced after the labral repair didn't work? Is the joint still a problem? And I don't think we know that either. And the thing that I raise more and more now is I think, what about just simply a failure of the labrum to properly heal? Going into that, when we look at our current repair technique, it does have a minor fundamental flaw to it, because when you look at the cross-section, here's the ball, the edge of the cup, here's our blood supply to the labrum. The first step does involve taking down the blood supply to expose the acetabular rim. Maybe some labrums can handle that, maybe some labrums can't, and I don't know which ones can and which ones can't. I think the procedure would be more perfect if through the process of some level of devascularization we were denervating the tissue, but I don't think we successfully do that. If you really, really think hard about this too, there are really no ligamentous or meniscal structures in the body that when chronically torn we still repair. And I think that we all would agree that virtually every labral tear is a chronic injury. Mattress sutures, there's a lot of hype and interest in this. I personally am a little bit concerned about them. I've taken out a lot of labrums, and I really equate the labrum to a marshmallow. The inner substance is really soft, the outer substance is your strongest aspect. And so sometimes when you put sutures through the labrum, I think unfortunately it can scissor through quite a bit. So whenever I repair something or reconstruct something, it's with circumferential sutures. I've revised quite a few hips that have been repaired with a mattress suture. This is one, Can I go back one? This is one that I did do a reconstruction on, and you can see here when I dissected out the suture, it had scissored down to the point where a 1 millimeter probe could barely fit through it. And so it felt good for this surgeon, I'm sure, to have the suture as more of a mattress type design, but unfortunately I don't think it was creating much stability. When you look at this, this is an example from the first talk that I gave. This is a really bad labrum. And the only reason why you preserve or repair this is because you value it for the patient. But I think being able to heal something like this or repair something like this to the point where it heals and becomes painless is going to be a real challenging situation. And so this takes us to the example here. This is a physical therapist from Denver that I repaired about 4 years ago. And about a year or two ago, I started having recurrent symptoms. It was a degenerative labrum, and I repaired it with about 5 or 6 sutures. He did really well for 2 years and started having recurrent pain. We did an MRI, it was suggestive of a re-tear. Diagnostic injection helped. And what you could see is this dense wall of scar tissue around the labrum, and the labrum was more hypermobile than it should have been, but overall a pretty healthy joint. And so the question now, you've indicated this person for surgery, what are you going to do? So for me, between 2008 and 2010, I did a lysis of adhesions to remove the scar tissue. I re-repaired the labrum and I touched up the bony work. I had too many failures with this, and so this is when I first converted over to doing labral reconstructions. And what I found with that was that the reconstruction simply worked better for me. It took away the pain and catching and allowed the physical therapist to rehabilitate this joint, and the patients said their preoperative symptoms or pain was gone, and they were able to make good progress. And it was working in very complex cases who had had open surgical dislocations, multiple hip arthroscopies, and I felt that that was because we were removing all of the painful scar tissue and labral tissue, and we were replacing it with a graft that was aneural and reproducing normal anatomy as my skill set improved. And I felt that it was a more definitive procedure for these patients. So the goal of this study was to objectively evaluate these two techniques for revision hip arthroscopy and try and determine which procedure gave me the best chance for success for this very challenging situation. And I thank my co-authors because it's been a tremendous amount of work to follow up. For the methods, we had 119 patients who had a revision procedures in two groups. One was the lysis of adhesions and the re-repair, which I would say is probably the standard now for revision procedures, versus the labral reconstruction, and both had some element of touch-up of the bony work. In the cohort, we had 15 patients who had a re-repair and 104 who had a reconstruction. We lost 1 to follow-up in the re-repair group and 11 in the reconstruction group for overall about a 90% follow-up rate, which for this population I think is really quite good, and it took a lot of work to get to that, to be honest. Our average age range, we're a little bit older in the reconstruction group, which if anything I think makes that a little bit more challenging to take care of. Our gender distribution was very similar. Our range of follow-up was a minimum of 2 years, but you can see an average length of follow-up was a little bit longer in the lysis of adhesions re-repair group, which makes sense because that's when I changed procedures. The results for the patients that did not fail, and we defined failure as the need for another surgery, we found an improvement of 28 points and 32 points, 21, 25, et cetera. But you can see nice improvements in all metrics in both of these groups. The trend shows a better result in the labral reconstruction group, but we were not different enough for it to be statistically significant. With the failures, which we defined as a need for another surgery, I had 7 of the 14 fail in the re-repair group. That's why I switched gears to the reconstruction. I've had 13 of the 93 fail in the reconstruction group. The time to failure shows that the majority of these patients failed before 2 years. That's why I believe this is a comparable cohort. And when you look at that failure percentage, you can see 50% failure rate in the re-repair group versus 14% in the reconstruction group, which is obviously statistically significant. So we concluded from that, in my hands, in my practice, for me, it is 3.6 times more likely to fail with the re-repair over the reconstruction in the revision setting. That's with a very narrow confidence interval and statistically significant. So the value of this study, it's a very large cohort for a rather unique patient population. We did show a considerably lower failure rate with the reconstruction group. So for me, in this bad situation, I don't want to leave it to a coin flip. I want something more predictable. I think this objectively validates the use of this procedure for failed previous hip arthroscopy. And what I want to do is I want to show the technical pearl for how you do this, okay? I'm going to show a video in the next section, and the key for revisions, the key for primary reconstructions, the key for getting low on the front of the cup is being able to do central compartment work in the peripheral compartment. It allows access to the bottom part of the cup and allows you to dissect from known to unknown in the revision situation. So we go back to that first case. If you try and tackle this in traction, you're going to eat out all of your capsule, you're going to beat up all the tissue, and it's going to be really, really hard. Okay? You can see that's the view down the posterior aspect of the joint. Now when we go out of traction, you can see that's the bottom part of the cup. Known. We have a nice cleft between the capsule and the labrum, and now we're dissecting against that nasty, thick, fibrotic scar. And that's how you come across, that's how you keep your capsule intact. And counterintuitively, the capsule is the key to being able to do a labral reconstruction. You want to preserve it. You can see we've separated that. We've kept our capsule intact. Now we've removed the labrum. You can see we're all the way down to the bottom. Our capsule is intact through the front. Rim, a little bit different than it would look in a primary setting. Some sutures you can't fully remove because they're grown in. But good looking cartilage. Okay, now we look in the peripheral compartment. Our capsule is intact. Our rim has been prepared. There's our graft in traction. There's the view of the graft with the joint reduced. And so if you can't work in the peripheral compartment, it makes this very hard. But if you can work in the peripheral compartment, that's the way to dissect it out and get rid of it. And then you can turn a complex revision into a relatively more routine primary case. The only challenge is that that capsular tissue is much more fibrotic, less pliable. It's harder to move around in the joint. If you're interested in these procedures, please come visit. I can help you through the learning curve. Thank you.